So my name is James Wilton. I'm an epidemiologist in the Applied Epidemiology Unit at the Ontario HIV Treatment Network, or the OHTN. And the OHTN is a provincial HIV/AIDS organization, but actually a lot of the work I do is part of a broader initiative called the Ontario HIV Epidemiology and Surveillance Initiative, or OEZ. So the cascade in its simplest form refers to a series of steps that people living with HIV need to progress through in order to achieve viral suppression. So the first step is HIV infection, and with the last step being viral suppression. And so the steps in between include diagnosis, linkage to care, retention in care, initiation of antiretroviral treatment, or ART, adherence to ART, and then finally viral suppression. So the cascade has become a popular way of sort of visualizing the gaps that may exist that prevent people from reaching viral suppression. And this is often done by using bars, so you know how many people are infected, how many people are diagnosed, linked to care, and so on. And you can actually see visually where people may be being lost. So the cascade is important for a few different reasons. First of all, we know that viral suppression is important for health and also for preventing HIV transmissions, and we've seen a number of new studies emerge, even over the past 5 years, that really emphasize the importance of early initiation of ART and achievement of viral suppression for health and preventing transmissions. So the cascade is important because it allows a way of identifying where people may be being lost and some of the barriers that are preventing people from enjoying the benefits of viral suppression. It's also important at the population level. So many people have heard of the term treatment as prevention, and that concept is closely tied to the cascade concept. So treatment as prevention refers to the idea that if you increase the number of people on treatment in a population and the percent of people in that population who are virally suppressed, then you're going to see benefits at the population level. So you're going to see decreases in new HIV infections within the population. It also has that public health benefit. So we're really seeing the cascade become sort of an organizing framework for the response to HIV, and a way of identifying how well we're doing with our programming, identifying where there could be improvements, and so on. So first of all, a major element of measuring the cascade is knowing how many people living with HIV there are in a jurisdiction. And this can't be directly measured and can only be estimated through mathematical modeling. And when I say the number of people living with HIV, I mean those who are diagnosed and undiagnosed. So there's always some uncertainties involved with some mathematical modeling, although they are rigorously conducted and based on data that is available. To reflect that uncertainty, mathematical modeling studies often, the estimates from these studies come with ranges to sort of reflect that uncertainty and try and capture where the true value may lie. So I mentioned that the number of people living with HIV cannot be directly measured, but the later steps in the cascade can be directly measured. And there's a few different data sources that can be used to measure things like linkage to care, retention in care, antiretroviral treatment use, and viral suppression. And you can sort of categorize these data sources into two different categories. One is sort of surveys and clinical cohort studies of people living with HIV who are in care. And these are really important data sources, but they're often relatively small and don't represent all people living with HIV within a jurisdiction, or all diagnosed people living with HIV in a jurisdiction, or all diagnosed people in care who are in a jurisdiction. So there's also other types of data sources that can be utilized that are larger and maybe more representative of a jurisdiction. And these often include data that's routinely collected, either as part of public health surveillance, as part of laboratory testing, as part of seeing a physician or getting certain treatments. A lot of this data is collected routinely. So these types of data sources can also be utilized to measure the cascade, and it may be more representative of a jurisdiction because it includes everyone within that place. But even with these larger data sources, there still are challenges with them. They can be challenging to access. There can be a lot of missing data. One data source by itself often doesn't include all the information you need to measure the cascade, so sometimes they need to be linked together, which can be challenging. So there's definitely challenges with both data sources. Last year in 2016 on World AIDS Day, the Public Health Agency of Canada released Canada's first national CASCADE estimates and 90-90-90 target estimates. And so what we saw there was that 80%, for the first 80% of people living with HIV are diagnosed. For the second 76% of diagnosed people were on antiretroviral treatment. And for the third 89% of people on treatment were virally suppressed. And these were estimates for 2014. And so what this shows is that we seem to be doing well, relatively well with the third 90 compared to the first and second 90. So this seems to suggest that once people living with HIV are in care and they're on antiretroviral treatment, they tend to reach viral suppression. And it really seems to be that there's larger gaps with the previous steps. So that suggests in order to prove engagement in the CASCADE in Canada, there needs to be efforts to improve HIV testing, to improve that first 90, and then also efforts to improve linkage to care and retention in care potentially, and also access to antiretroviral treatment to improve that second 90. Comparisons are always challenging, particularly with the CASCADE. So earlier I was talking about that there are difficulties with measuring the CASCADE. And some of the limitations of available data sources means that sometimes CASCADE steps are defined differently and approaches are different based on the unique limitations with these data sources. So that means the approaches between jurisdictions can often be different, and this can affect the CASCADE estimates. So I think this is a big caveat when comparing between different jurisdictions that have different approaches. And that's not to be said that there haven't been a lot of efforts to standardize the CASCADE. There have been, but just the ability to reach and achieve those standardized definitions is often limited by the data sources that are available. So that being said, it seems that Canada is about in the middle and comparable to other high-income countries. But again, comparisons are really limited by the different data sources and approaches used. And I think probably the most useful use of CASCADE data is to compare within jurisdictions where the approach being used is consistent. So there's been great efforts to put together these national estimates and to put together provincial level estimates as well. So for example, on World AIDS Day, Canada released their national estimates, and recently OEZ released a report showing the overall estimates for Ontario. So really the next step is to start looking at the different populations and different groups within those jurisdictions, because I think that's what people on the front line and policy makers really need to make some decisions and to inform programming as well. The importance of the CASCADE is really being recognized at the policy level. So we've seen the UNAIDS 90-90-90 targets released. So that refers, and the UNAIDS 90-90-90 targets are closely related to the CASCADE concept. So it's a strategic direction set up by the UNAIDS where by 2020, 90% of people people living with HIV will be diagnosed. 90% of diagnosed people will be on treatment, and 90% of those on treatment will be virally suppressed. So it sets some strategic directions for jurisdictions to strive for. These breakdowns are really important to inform policy and programming. And I think it's not just about producing data, it's about producing data that's meaningful and that can inform policy and programming. So I think that it's important that the CASCADE is produced through collaborations that involve people who have access to the data, as well as data analysts and epidemiologists, knowledge exchange experts to make sure that it's in a format that can be used, and also with frontline service providers and policymakers who are actually going to be using the data.